So let's talk a little bit about cytokines. And this is another one of those things that when I first started lecturing on cytokines, people are like, why are you talking about this? It's so esoteric. And of course, now biologic drugs have become the mainstay of modern treatment for anything and everything. So what are cytokines? They're proteins, they're soluble proteins, so they don't need any kind of carrier. They're released by immune cells and endothelial cells, and then they travel all over the body in response to inflammatory triggers, to trauma, infection, food, and toxins. Remember that. Trauma, infections, foods, and toxins. So when you've got somebody with an inflammatory condition in front of you, that's what I want you to run through in your mind. I want you to remember this the rest of your career. Trauma, infection, food, toxins. What could it be? I could also add allergen on there, I suppose. But really if you're talking about somebody with rheumatoid arthritis and you're trying to figure out what set this off, walk through that algorithm. So trauma, infection, food, toxins activate immune cells to release cytokines. Which are messengers that then turn on other immune cells, help recruit other immune cells. And they do this by something called signal transduction, which we'll talk about in some detail. What are the classes? Interferons. You've all heard of using beta-seron for multiple sclerosis. Or we used to use alpha interferon for viral hepatitis. We don't use it so much anymore. And by the way, what's the main side effect when you inject somebody with interferon for hepatitis? They feel terrible. They get muscle aches, pain, mood disorders, depression, etc. So that's why people talk about chronic gut inflammation as being a source of cytokine sickness. What is cytokine sickness? When you're overproducing low levels of these inflammatory cytokines that cause pathology. Okay? So keep that in mind, because if we go upstream, then we can say, how do we cool off the gut so you're not producing these inflammatory cytokines and the mood gets better? There's interleukin. Interleukin 1 is used in medicine to treat melanoma. Used to treat melanoma. Not so much anymore. TNF-alpha, we use TNF-alpha blockers extensively in rheumatology. Transforming growth factor is involved in scarring of the liver. People that get cirrhosis have very high levels of TGF. So these things are involved in a lot of different kind of pathologies. So here is a macrophage acted upon by inflammatory stimuli, and depending on the tissue that's receiving the cytokines, you're going to get slightly different responses. If macrophages are activated releasing TNF-alpha, then you get skeletal muscle catabolism. You get sarcopenia. But TNF-alpha actually makes adipocytes get big. So what happens if you've got a scenario like leaky gut, where you have an inflammatory trigger like lipopolysaccharide? The lipopolysaccharide gets across the gut wall, activates macrophages. On a low but chronic level, the macrophages make inflammatory cytokines, so you have metabolic endotoxemia. And that can actually lead to diabetes. Right? Does that mechanism make sense to you? So it's not an acute inflammatory trigger, it's a chronic inflammatory trigger. As I've mentioned, there's this huge mind-body connection going on. I've talked about cytokine sickness, and it really raises the question of what mood disorders are. Actually, what's the pathophysiology? Is it a simple deficiency of a neurotransmitter? Or is it an inflammatory scenario? We know we can induce depression by injecting people with cytokines, with inflammatory cytokines. Right? So doesn't it kind of stand to reason that we should be going after the inflammation in people that are chronically depressed? Maybe it's worth taking a looking at simple mediators like C-reactive protein. The interesting thing to me is how nature does this double duty. You have these autocoids, serotonin, histamine, substance P, nitric oxide, something peptide, what is it? VIP. We'll call it VIP. Somebody know? Vasoactive. Why is it VIP then? Oh, vasoactive intestinal peptide. I'm stuck on that I, man. I could have spent an hour. You realize? I could have spent the next hour. How did that I get in there? What does that I stand for? But all of these things, the nature does double duty. They're just trying to save money. Right? Trying to save money. Well, we already got the histamine. We might as well use it somewhere else. Oh my God. They're neuromodulators and neurotransmitters and inflammatory mediators. So again, what does that suggest? It suggests that you treat the inflammation and the mood issues get better. Wow. I think that's pretty darn profound. So what turns on the cell to make cytokines? Signal transduction. And what is signal transduction? Signal transduction is when you have one kind of energy that gets converted into another kind of energy. So you have molecular structure energy that gets converted into kinetic energy or genetic transcription energy. And this is how this works if you're feeling totally confused by that. So we have a cell surface receptor for sticky buns, right? An AGE, advanced glycation end product. That's what's on a sticky bun. Or TNF-alpha, or a pathogen-associated molecular pattern like what you get on the surface of the yeast. Okay? So let's say this is this front row of tables here. This is the cell membrane. And let's say I'm a sticky bun. Right? Person eats the sticky bun, goes down the esophagus, ends up interacting with cells in the submucosa, with dendritic cells, hits the surface of the dendritic cell. The dendritic cell goes, whoa. What are you, dude? I don't like you. I think you're bad news. So you're bad news. So inside the dendritic cell, some action goes on, right? And the action is just like I was describing in the mast cells. That was signal transduction when the IgE binds to the antigen, and then there's a conformational shift in the protein. So then the surface of the dendritic cell binds to that structure on the advanced glycation end product, looks at that glycoprotein structure and goes, oh, like that, leans back, and what it's got in the picture arm is a hot potato, and that hot potato is a phosphorus, right? And a phosphorus gets thrown and hits an enzyme called a kinase. So whenever you hear a kinase is an enzyme that utilizes the high energy of phosphorus. So the dendritic cell throws the phosphorus hits a kinase, it gets activated, throws another phosphorus, boom, 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 all the way back to the back of the room. In the back of the room, there's this black Cadillac. Okay? The windows are tinted. You can't see what's in there, but what we know is the famous guy is in the passenger seat, and there's a driver in the driver's seat, and the hot potato comes through the window, knocks out the driver, and the famous guy turns out to be Batman. It's Bruce Wayne, right? And he looks, and this driver's knocked out, and he goes, I'm mad. So he throws out the driver, gets in the driver's seat, pushes a button, and the Cadillac turns into a bat car. Wings come up. I'm activated. And that activation occurs right here. Nuclear factor kappa B. It's activated. The bat car goes through a special tunnel in the nuclear membrane, and lands on its special little bat cave right on the DNA. And when it lands on the DNA, it tells the DNA to make inflammatory cytokines. All that because of a sticky bun. Or a Candida albicans, right? That is happening inside of you right now, because I know there are people in this room that ate something for breakfast they probably shouldn't have. Now, you want to know something funny? If you want to down-regulate inflammation, you want to dial it down, probably the most effective intervention that's ever been discovered is fasting. Is fasting. Simply by not eating, you down-regulate this whole system because you turn off all those kinase pathways. Now, there's pros and cons of fasting. You know, for one thing, you get hungry. Right? There's downsides. Some people tolerate it, some people don't. But, you know, there's some pretty interesting research on fasting mimicking diets, intermittent fasting, time-restricted feeding, going overnight for 16 hours, etc., saying that you can tone down this whole system. So obviously, a big part of upregulating it is eating inflammatory foods like sticky buns, right? But how do you downregulate it? By not eating at all. Because everything you eat is going to activate the system to some degree. Are you with me on that? So the future is all about figuring out what kind of fasting is appropriate for which individuals. But it's a very profound intervention. So NF-kappa B, it's a transcription factor, BACAR, right? It's normally inactive, right? But then it gets activated. It's phosphorylated, so there's inhibitory. The handler, that's the driver, is inhibitory kappa B, right? IKB. And it's sitting there, it's keeping this guy, you know Robert Downey, right, that played Iron Man? So I guess he has to have a handler to keep him out of trouble in between movies. So a lot of these movie stars, you know, they get into trouble and end up in jail or whatever. So you got to have a handler, and that's what I-kappa B does, is like, let's keep the star out of trouble. And that's what you're doing with NF-kappa B. Let's keep it out of trouble. But when the phosphorus comes in, it phosphorylates I-kappa B, it moves back from NF-kappa B, it becomes activated, binds to DNA, starts making all kinds of inflammatory chemicals. Now, this is the final common pathway for almost all inflammatory triggers, right? So pretty critical that this works correctly. It's also involved in cell survival. Cancer cells have NF-kappa B that's turned on indefinitely. So what activates it? Infection, tissue damage, our old friends. Trauma, infection, foods, and toxins. Same kind of triggers all hit NF-kappa B. What are dietary or disease states that lead to NF-kappa B upregulation? Eating too much. Chronic overeating, which is kind of a societal problem that we have. Any chronic inflammatory state is associated with too much NF-kappa B. Excessive visceral fat, diabetes, cardiovascular disease, hemochromatosis, lipopolysaccharides that I mentioned that can come from leaky gut syndrome. Any chronic infection, cancer, autoimmune disease, depression, right? Depression is an inflammatory state. And just getting older leads to the BACAR getting activated more often. So how do we turn it off? Give people prednisone. Wow! Or calorie restriction. You choose. Think about it. Fish oil, alpha-lipoic acid, N-acetylcysteine, which is a precursor to glutathione, antioxidants, spice-derived phytochemicals like rosemary and curcumin, quercetin, green tea, pomegranate juice. It turns out that most herbs or foods that are known to be anti-inflammatory down-regulate NF-kappa B, right? So this is a prime example of how we go upstream, of how we can work with diet, we can say, well, eat berries every day. Every single patient that I see, I tell them to eat berries. 100% of people. Everybody does fine with berries. I almost never hear people saying, I have an allergic reaction, I can't digest it. So, the blueberry diet. And I'm going to get mad if one of you comes out with a book with that title, because I've had this happen. Give a lecture on something, and then a month later somebody says, see my new book. I'm like, I just lectured on that. So imagine pathogen-associated molecular patterns, right? It's just an example. All these different triggers have patterns. So a pathogen like Pseudomonas or pathogenic E. coli has got a pattern that binds to a receptor, and that is working just like the sticky bun to set this process in motion. So now let's take our algorithm, antecedents, triggers, and mediators, and give you an overlay of this blueprint, right? So it's not quite as simple as just antecedents, triggers, and mediators. It's more like we have these sentinel cells like dendritic cells and macrophages, neutrophils that have receptors that interact with the molecular triggers. And if that goes on over and over again, then you have a release of endogenous mediators, which would be the eicosanoids. And in a person with an antecedent, they're set up. And what could those antecedents be? Well, there's a genetic antecedent. A person could have an exceptionally sensitive trigger for sticky buns. Right? I'm not making this up. So, a toll-like receptor for single nucleotide polymorphism that binds to lipopolysaccharide in a particularly strong way. Okay? So you respond to the triggers more actively, so the body is more sensitive, so maybe just one little bite of the sticky bun. You know, and we certainly know that with celiac. Probably everybody's sensitive to gluten to some degree. But people with celiac, some of them can't tolerate parts per million. Other people can have a bite or two and it's not a problem. Other people can eat a whole pizza in one sitting. You know who you are. Right? But that doesn't mean that the gluten isn't inflammatory for everybody, but there's a wide range of sensitivities to the gluten. That's what the antecedents are all about. And then the gluten is the molecular trigger that's binding to the receptor on the sentinel cell, that's then releasing its endogenous mediators, the cytokines, the eicosanoids, the histamine, and that leads to inflammatory response. A clinical pearl. Where's the largest source of exposure to inflammatory trigger? The mucous membrane. So, you know, Metchnikoff says death begins in the colon, right? When in doubt, treat the gut. When in doubt, treat the gut, because that's where the biggest exposure is. Now, I would add to this, also think about the lungs. Think about the lungs, because now we know that autoimmune diseases may start in the lungs, and we've got a huge problem in this planet right now of air pollution. And we're kind of discounting what air pollution does, how it creates a chronic inflammatory state. It's one thing to say, hey, well, we know that cigarette smoking is bad, but some people are breathing the equivalent of 1 to 2 packs of cigarettes a day just by living in a city. Right? We need to consider this even more. And you're going to hear a lot more about this in the lecture on detoxification tomorrow. Local inflammation can lead to systemic response. Saw a patient not that long ago, did a general blood profile on him. C-reactive protein was like 7. And before I just checked his blood pressure and heart and lungs, etc. And I'm like, let me look in your mouth. I wished I hadn't. I'm like, dude, so his C-reactive protein is super high. I'm like, when's the last time you saw a dentist? I don't remember. Oh. Well, I want you to go see a dentist right away. He got a cleaning, and his C-reactive protein dropped in half. Okay? So, gum disease can lead to heart disease. and maybe Alzheimer's disease. So always look at your patient's gums, right? It should be, I should have done it before. I shouldn't have waited till I saw his CRP was up. And how does this work? You have this local inflammatory response. Those cells are releasing inflammatory cytokines, which can go to the brain. If there's a lot of them, can go to the brain and produce a fever, can go to the adrenal glands that produce glucocorticoids, or can go to the bone marrow and cause leukocytosis. So it's not always a systemic phenomenon. Smoldering article. This was a big story when I first started lecturing on it, but I've kind of left it in for historical import, that coronary heart disease is an inflammatory disorder. Right? This is a big deal. It's not a cholesterol storage disorder. So we know that if somebody gets pneumococcal pneumonia, their CRP goes way up 10,000 times. But it was a bigger discovery to realize that you can get slight bumps in CRP if you're overweight or if you have pre-diabetes, right? That this chronic inflammation, the metabolic endotoxemia, can precede diabetes by years. And yet, I still get pushback from insurance companies that say, you shouldn't have ordered a CRP on that patient because it's an experimental test. You ever get that? This happens. I think that's crazy. CRP is very useful. Martha and the Vandellas, of course, were the original cardiologists who said, it's a heat wave burning in my heart. And this is what I just told you, CRP, interleukin-6. So CRP is just a surrogate for interleukin-6. You make interleukin-6, the cytokine first, and that tells the liver to make CRP. So some people say, measure IL-6. Well, it's more expensive, so it's a higher level test. But CRP is kind of a routine test we should be doing on everybody. The difference in acute and chronic inflammation, acute is generally a good thing, right? Maybe not an anaphylactic reaction. That would be an acute inflammatory reaction. But most of the time, acute reactions are good, like the person that had the wound that you saw sewn up, right? This is a good thing. It's chronic inflammation that's the problem. This is a persistent acute phase response, which sounds like a contradiction in term, but that acute phase response is this predictable systemic pattern that you get in response to the gum disease or the cut or the damaged arteries, etc. So inflammation is always at once localized and systemic. Does that make sense? It's localized and systemic at the same time. Chronic inflammation is maladaptive. It's never a good thing. It's self-perpetuating. Once it gets going, it's hard to stop. And that's why I'm not against going downstream. I'm not against DMARDs. I'm not against methotrexate or biologic drugs by any means. If there's a fire, put it out. One of my mottos in medicine is first treat the symptoms. Right? And I know people that say, oh, I'm going to put you on the probiotics and we're going to change your diet. But the person goes, but my joints ache. Right? Treat the symptoms or the patients won't come back. If they got a bad cold and you're saying, well, it's clear that your immune system, needs some long-term boosting because you're getting sick all the time. They're like, yeah, but can you give me some cough medicine? First, treat the symptoms. Always. Get people feeling better and then work underneath, right? To start understanding what are the conditions that led to the problem. Chronic inflammatory disorders, atopic syndrome, autoimmune disease, inflammatory bowel disease, atherosclerosis, neurodegenerative disorder, Parkinson's, Alzheimer's, cancer, diabetes, mood disorders. All of these things are amenable to this approach that I'm talking about. So the question that's being begged here is, why do we have this epidemic of inflammatory disorders? Because we do. Any chart that you look at diabetes, look at Alzheimer's disease. Every one of these diseases I'm mentioning is on the rise. Is it because we have more bad genes? Suddenly we inherited all these bad genes overnight. Is it because we eat a glycating diet? I tell my friends, you want to go glycate tonight? Let's have some sticky buns or some ice cream. I can't buy it. If I buy it, we have this ice cream place that's like a 5-minute walk from my house. I can't, if I buy it, it's like, it's just a pint. I can last a week with that, right? And then the next day it's gone. What happened to it? Right? Just don't put it in the house. This is our problem, is the things that are so bad for you, like ice cream and French fries, taste so good. Right? So, you gotta have a certain amount of willpower. We don't have enough antioxidant phytochemicals. Most people outside of this room eat lots of processed foods. Right? So they're not getting the antioxidants that they need. And the first thing to do is put them on more blueberries, etc. We don't have enough endogenous mediators to turn off the inflammatory process because of an insufficient intake of omega-3 fats. And then we don't have enough T regulatory cells. And those T regulatory cells that suppress immunity just to the right amount, those originate in the gut. And one of the best ways to induce them is with probiotics. So this is from the journal Science. It goes back and revisits this concept of the signal transduction cascade. The signals bind to membrane receptors, activate this kinin cascade, right, which is basically throwing hot potato phosphoruses around. And then that turns on NF-kappa B, which activates genes, which release regulatory proteins. Now, here's what I want you to get. This is a huge take-home message from this lecture. This could be the same signal. Could be a sticky bun or a yeast. But look at all the different ways it can play out. So a yeast overgrowth could lead to cancer, pro-inflammatory disease, autoimmune disease, or depression. Are you with me on that? So the same trigger. Now, probably yeast is not the best example because people kind of overrated yeast, but yeast is a highly inflammatory trigger, so, we can include it. I don't think yeast causes cancer, but again, the same kind of basic things, pathogens, pathogenic microbes, toxins, foods, all of these things are working through the same pathway, but depending on the individual and their antecedents and their predispositions can lead to very different kinds of diseases. So, you know what? We're too clean. Our whole society is way too clean. We're paranoid about getting babies exposed to the public. Babies get born by C-section and lose the microbiome from their mother. Their microbiome looks more like the skin of the mother than the vaginal microbiome. So we're starting out in life with fewer and fewer microbes. So maybe this too clean thing, coupled with not enough plant-based antioxidants, is this setup. It's not that we have more bad genes. We're just being set up for a problem. So the adaptive pattern of an earlier time, when it was a good thing to have a vigorous immune response to wounds, etc., when people were eating foods that more likely had infection in them, right? It's good to have a vigorous response to that. But now our immune systems are all dressed up with no place to go. We sit in front of our computers all day, filling out forms for our electronic medical records. This is what we do all day. So our immune system's all dressed up, ready to party, right? Ready to be a warrior. And then you go out and have a donut. And it's like, well, I got nothing else to attack. I might as well go out to the donut. This is what's happening. This is the world that we live in. Okay? And people don't die from infection. People used to die from infection when they were young. That was the #1 cause of mortality. Now we live longer. We don't die from infection, but instead we get this kind of chronic inflammatory condition. So how do we deal with this with drugs? Inflammatory trigger activates NF-kappa B. NF-kappa B activates lipoxygenase, cyclooxygenase. So we got these great drugs. We got corticosteroids, NSAIDs. We've got leukotriene inhibitors like Singulair. We've got biologics like etanercept. Isn't that great? Well, it's fine. Treat the symptoms first. Get the person better. Although, I mean, I have to say that, the trend now is to start DMARDs like early on. Oh, your little pinky is sore? Time for methotrexate. I see this all the time where people are, we don't need to be that aggressive in the beginning. Have you tried a gluten-free diet and some fish oil? Do that first, right? Go there first. So these are the drugs that we give them. Functional medicine basically says it's a process. It's a process in looking at the environment, maybe doing some genetic testing, the diet, how is the body responding to that diet? What are the inflammatory systems? So this is another perspective. NF-kappa B leads to activation of all these different pathways. Doesn't that feel good? I'm going to do that again, just so you can see that. Phytochemical immunomodulators. Just imagine them raining down. Oh my God. Don't you want to stand in that shower for hours? Do I really have to get up and see patients all day today? I think I'm going to do that one more time. Oh! Phytochemical immunomodulators. We've talked about them, and I'm giving you a list. Fish oil, niacinamide, alpha-lipoic acid, NAC, probiotics. Turmeric, ginger, boswellia, bromelain, devil's claw. There's a long list of them. Start with one. I recommend curcumin for most people, right? It's a really good herb to get to know, start working with it, get a sense of what works well for your patients and in what dose and how do they tolerate it. But there's a long list of them that are worth becoming friendly with. And we've got all this information in your toolbox. My objective today is just to give you the ideas, to plant the seed that you can use these in a different way. So what have I said? Inflammation is normal. It's triggered by molecular structures, trauma, infection, toxins, or food. Most chronic disease are linked to inflammation. How do you get inflammation? When the trigger is still present. So look for the trigger even if it's not obvious. Or ask the question, what is it about the person's physiology that keeps them from turning off the inflammation? Pharmacology is working downstream, and that's not a bad thing. That's a very useful thing, but that's the starting point, not the end point. It's the starting point. Functional medicine goes upstream to look at all the conditions that are involved that allow this phenomenon to occur. So we can dampen inflammation by avoiding exposure to triggers and modulating the mediators by changing people's lifestyle, their diet, and nutraceuticals. And that, my friends, in a nutshell, is what functional medicine is all about.